Welcome back. Thank you for staying with us. Joining me now is PS Nicholus Muraguli from the Ministry of Health. Thank you so much for coming in this evening. The last time you and I sat across each other, we had a rather heated conversation surrounding the sorry state of cancer patients. So before we get into more of our conversation, I want to pick up from where we left off. We saw their images lying at KNH unattended. What is their state now?
What we have done is we have set up a committee chaired by the social worker, and they're evaluating case-by-case basis. To give a context, every day Kenyatta receives 100 patients who come for chemotherapy. Those are drugs for fighting cancer. We also get 150 patients for radiotherapy. So what we have done is isolate each case. Some are able to go home and come back. For those who are not able to go home, we are making our arrangement for them to be admitted in the hospital so that they can continue with their treatment. At the same time, a number of well-wishers combined with Kenyatta Hospital have also planned for meals, provision of meals. So they're already getting some meals with support of Kenyatta Hospital and partners who have come on board. Moving forward, the solution is basically decentralizing those services, because all of these 100 patients who come for chemotherapy is now available, can be provided in level 5 hospitals. So we have tasked 2 specialists to start moving county to county to set up and support county to be able to start treatment at that level. For example, it's happening in Meru, it's happening in Mombasa, it's happening in Kisumu and Nyeri. So these specialists have been supporting county doctors to be able to provide chemotherapy at county referral hospitals.
So now the hospital is actively referring them to these hospitals? To
counties as well. So the idea is over time, all these 100 should be able to go to their counties and be provided for chemotherapy services. So that we only leave for the 150 who will be coming for radiotherapy until we set up the systems later for provision of expanding our capacity for radiotherapy. But at these 100 should be able to be distributed now to their counties with support of the specialists from Kenyatta. So basically people should be able to access treatment back home.
But as we speak, are they still in the corridors?
No. So that's why I said we set up a committee chaired by a social worker.
They've been moved.
You have been trying to review case-by-case basis. Some of these people are not even aware that services are available at the county level.
Right.
So we are reviewing case-by-case basis to ensure that people are informed and supported to be able to be provided care back home.
And yet, unfortunately, the same situation is unraveling with kidney patients, to be specific. Where does the problem lie there? Is it still that the services are available at home and people don't know about it, or what is the challenge?
Now, to give a context, every year we have 10,000 people who need dialysis, and for a long time only 1,000 received dialysis services because only 2 centers were available that were providing care. That is Kenyatta National Hospital, Moi, and Mombasa on and off cases they were providing dialysis services there. Now we have been able to expand that capacity by next month, basically in each county. And I'm happy because of what will happen. We're able now to absorb the other 9,000 who are not getting care. They are simply dying unattended. So once we decentralize, moving from the 2 centers with the 44 beds, and then moving to we are going to have 245 new machines across 47 counties. So basically this is decentralizing the services where people are. So that's the solution, and we are hoping that as we move forward, more and more Kenyans will need to know that they don't need to come to Kenyatta or Moi Referral Hospital for dialysis. Dialysis centers will then be available at the county level.
So this is going to happen?
It's going on. Okay. I mean, so far we have done 40. So 7 to go. By next month we are done. We now have in Homa Bay services being available in Homa Bay, Longisa in Bomet, and all these people were actually coming to Nairobi. So in the next 2 months we should be able to see people in Turkana get the services, people in Lamu getting services, and so on. So the idea is we decentralize these services. It will be the biggest program in Africa actually, where people are able to access care in their own counties.
So perhaps which counties then are yet to catch up, the 7 that are remaining?
So the 7 that are remaining is basically a Hola, and the 7 are basically the problem is that they are actually building new infrastructure. We also have Narok that is building new infrastructure. We have Wajir that is building new infrastructure. Mandera that is building a new infrastructure, and so on. So there are basically 7 remaining, and these are the counties that are ahead to construct a new facility. And of course Meru, but we are already working with the team to ensure that we are able to bring in the machines.
Okay. And so the big message is you can get these services from your county, but specifically when it comes to kidney problems, there's a related challenge when it comes to the cost.
Yeah.
And the unfortunate part of this is that this is a lifestyle disease. And if you were to take specifically the demographic that is most largely affected in the, is it about 10,000 new cases every year, you're talking about people in their 30s, correct?
Yes.
A lifestyle disease. If you go on social media, the craze right now is binge drinking. It is glorified. Are we looking at a public health crisis in the making?
It is already a public health crisis, because you look at the over 10,000 patients with chronic renal failure, 70% of those numbers are due to either diabetes or hypertension. And you look at the risk factors for diabetes, it's basically smoking, obesity, and unfortunately 30% of Kenyans are obese. Women being more obese than men. Of course, in some communities that is okay, but it's also a risk factor for diseases. We know 5% of Kenyans may have diabetes. Unfortunately, most of the people with hypertension, 25% of Kenyans with hypertension, do not know. So we see them with complications of diabetes or hypertension as chronic renal failure. So the programs around addressing the risk factors, early diagnosis, so that you can be able to stop the inflow of 10,000 patients. Basically ensure that people know their hypertension status, people know their diabetes status, so that they're able to be started on treatment early, so that we prevent the influx of these 10,000 patients who need chronic renal failure. Of course, we have a few, like 4,000 to 5,000 patients who are we call acute renal failure, who may need care, but that's isolated, which this follows infections, but largely 70% of patients with chronic renal failure is due to either hypertension or diabetes. These diseases are preventable, actually, if you are diagnosed early. So part of the program is to ensure that we're able to expand the screening programs so people know. On the issue of treatment and the cost of treatment, it costs in the between 5,000 and 10,000 per session. Usually you have to be dialyzed twice, that is 20,000 a week.
So 80,000 in a month.
In a month. We have also addressed that issue with now NHIF. Anybody who is an NHIF members, and close to 6 million Kenyans are NHIF members now, they're able to get free dialysis services. And we are also now looking at transplant, because anybody on chronic renal failure treatment now
need a transplant.
We need a transplant. We are also looking at that transplant program, and NHIF now pays up to 500,000 shillings towards the transplant. Because at the end of the day, we need to have an exit plan.
As we wind up, I remember at the launch of the Jubilee Party, I believe it was a kidney patient telling the president that the law around transplants also needs to be changed so that they can get this from non-family members. Is that something the ministry is considering and working on in terms of legislation? Oh,
there's a lot we are doing around increasing access to transplant organs. So, and that is one of them, basically opening up to non-relatives. We also look at cadaveric, so people passed on will be able to donate part of their organs for transplant. So we have what's called Tissue Act, which is being reviewed to make it more enabling for people to be able to access transplant services.
All right, I thank you for your time, Dr. Nicholus Muraguli, PS Health.
Thank you so much.